So I'm just going to give you a brief summary of Trinity Health in case you all aren't familiar, because there are no Trinity Health hospitals in the country today. They all have different names. In Illinois, there's Mercy Chicago, Loyola University, McNeil, and Gottlieb. But we are a large mission-driven organization and really committed to serving those who are poor and vulnerable through transforming our communities. And we're, as Alyssa said, we're in 22 states across the country. We have over 130,000 colleagues and 93 hospitals. So our reach is large. I always like to say our opportunity is great, and our collaboration potential is even greater. So as part of our system, we launched a strategic plan, and as Alyssa also said, I recently came from the Chicago Health Department, and before FAB came to be, the notion of strategic planning was rooted in Illinois because of I-plan requirements. But I'd never worked for a mission-driven organization before, which was, I know in a strategic plan you are required to do a vision, mission, values, but those things usually get put on a shelf and put away until you bring it out the next time. But I have the pleasure of working in a place where the vision and the mission are present every day, everywhere. And we have a strategic plan really working to build a people-centered health system where every entity within our system, including our hospitals, our primary care facilities, all the ancillary services that we do, work towards these three pillars. And if one of these pillars' legs is broken, then we're not going to be successful. And so many of these things, hospital care is pretty normal for health systems, but the population health management and community health work is not as typical and is much more difficult. So we see ourselves in the community health space as leadership nationally, and really how do we put ourselves out there, test new ideas so that we can give that information to our local hospitals and they can take it and work with their local communities. And we've all seen variations of this slide, but the purple is really where community health and well-being focuses all of our energy, and it's addressing everything outside of the health care access and the quality of care that's happening in hospitals, because really that's their job, the deliverers of service, and we want to try to address all the environmental factors. And as Julie was speaking about community benefits, so when ACA passed and we were all required to do the community health needs assessments and really sort of get to the what are the requirements at hospitals, we're expected to do these needs assessments to identify priorities and to act on those priorities. Our allocation of resources doesn't really match the way we would address the problem or the need. And coming from a local health department, you know that while the greatest need may be these environmental or social factors, you get categorical funding for infectious disease and for environmental health, and so the need may not be great, and there's no sort of hierarchy of preference on what you should fund, but there should be a better balance. And so we're really working hard to create that balance. While clinical care, this slide is really stark to us who work in this field, that we want to assure the access to healthcare, of course, and we don't want people who can't afford healthcare to not have access or to not receive it. But of our $1.1+ billion that we invest in community benefit every year, a fraction, the teeniest fraction, goes to something that is not covering uncompensated care. And so we want to do our best to use those teeny tiny resources to the best of our abilities, and really move from shrinking that clinical line a little bit because we're more efficient in the delivery of care, and we have policies in place that ensure people have access to care through insurance, so that we can invest in the future, invest in prevention. And we really do that through policy, system, and environmental change. As Brian was speaking earlier this morning, those 9 policy areas are evidence-based. We know they make a difference in communities. If you have these systems in place, you're designed for success, and in the way we design ourselves is the outcome we will get. So if we design ourselves to only treat people, we will just continue to treat people, instead of help them to be able to be successful and create environments that allow them to be successful. So the work that I do fits in the dark purple column for the most part, but we sort of see ourselves as working with communities in partnership with communities to address all the different environmental factors, the education opportunities, and then also thinking about other big sort of health policies. Tobacco 21 is a huge opportunity that we're working on in every single one of our states. As a large health system, we do have system goals, so every single hospital works towards the same goals, and those are four. We have a tobacco goal, an obesity goal, community health needs assessment, which is actually local and is different every place, and then how we're starting to address the social determinants of health. And really, the tobacco aim is, as I loved Brian's little big circle slide this morning, where tobacco was the giant circle, and it's the leading cause of preventable death in our country. And you cannot deny that if we have better policies in place, there are fewer smokers. So our effort is to really get every community that we're in to have the strongest indoor air acts, the strongest tobacco control policies, and the greatest restrictions to access tobacco. And then a couple years ago, we started thinking about obesity, really focusing on childhood obesity and how that could work. And for most of you who I know are not hospitals in the room, hospitals don't really treat children very often. There are children's hospitals, of course. But people over 65 are the most regular visitors to our health system. And so to try to get our health systems to agree to work on children when they said we don't even see children was a challenge and very difficult, but I'll tell you a little bit more about that in a minute. And then really trying to get our brains around how do we address the social determinants, what does that even mean, and what should our focus and priority area be, and over the next year we're working to figure that out. So in 2016, to try to help inspire and encourage and support our local hospitals to do this work, we launched the Transforming Communities Initiative, which is the handout that you have on your table, where we invest over $3 million every year to these 8 communities to really create multi-sector collaborations and to do evidence-based policy system and environmental change. For the most part, I try to say we fund 0 programs, but it's not really true. There are a couple programs that are in there, but we really fund policy people to advocate around legislation. We fund school personnel to move school wellness policies, to strengthen school wellness policies. We revitalize playgrounds. We give them equipment and materials so they can be active in their classrooms. We work on complete streets issues, doing complete streets assessments, and in all of these communities, we're doing different things. But I think the greatest learning from this was we said we're only funding people who are already in existing coalitions, who have local public health at the table. That was a requirement. And little did I know that that meant something different to every community. In my head, public health means government public health. But in their heads, it did not. So that was a huge learning from a hospital perspective. And as you may or may not know, the guidelines around community health assessments for hospitals is that they must engage with local public health. But again, that might mean a public health institute, which is great. You don't want to, not say you shouldn't partner with public health institutes. It might mean partner with your local MPH program. But then the local government policymakers were not engaged at the table, is what we found in most of these communities. And so I spent a lot of time connecting dots with individuals around, this is who your local health department is, city, county, whatever the case may be. How are you guys collaborating? How are you supporting each other? What things are you already doing that we can help accelerate? We aren't trying to create new things. Communities do really good things. They just do them in silos. And so how can we bring people together to be more successful collaboratively? The other entity that we require to have at the table is local education agencies, and so either early childhood or K-12. So that was even more foreign to hospitals because they really don't work with, public schools. So that's been a journey, and hopefully you'll see more about our partnerships with local public schools in the near future. We focus on these 6 evidence-based strategies, and we also require communities to match 50% of what we give. And I was real skeptical about that requirement. and because I didn't think that that could happen. I worked in local government for a long time, coming up with matches near impossible, and we don't allow federal match as a match opportunity. But literally millions of dollars have been leveraged across all of these communities, particularly from businesses, because they saw the value in removing crime and creating job opportunities, because many of these communities are low income and there aren't qualified people coming into the workforce. So I was really surprised and continue to be surprised. We're only 18 months in, the amount of money that has been leveraged and seeded to other projects. The other really awesome opportunity that health systems have, and if you are working with any place in your community, is to talk to them about social responsible investing, about investment opportunities, because hospitals, nonprofit hospitals, have these resources. They should be reinvesting them back into your communities. And if you have community health centers that need a facelift, for instance, or a new community health center, or an early childhood center that you just don't have the capital that you need to do this, hospitals can loan this to you at a really low rate. Trinity does. Many of our Catholic peers do this as well. So particularly if you're in Illinois in the Loyola or Mercy area and you're interested, we definitely want to talk to you, because we have capital that just sits on our books that is only earning money, and we want it to be earning in your community. So that's the other opportunity. Through this work, we're going to reach hundreds of thousands of children, which is really exciting to me, because they're the future, and we want to create a future that is healthier and more educated and more engaged in their communities. And so as this goes on, we will be publishing regular reports on our evaluation to demonstrate to hospitals that, in fact, if you invest in this resource through community benefit, this will make a difference in your community, rather than some hospitals who say, I'm going to donate to this golf outing, which is not okay, or I'm going to donate to this entity and just sprinkle a bunch of resources around because it feels good. Feeling good is nice, but doing good is even better. So we really are trying to, at least at our system, ensure that any investment we make in a community is strategic, is aligned with our strategic priorities, and is making a measurable impact in the communities that we serve. So we've had great success focusing on Tobacco 21. We partner with the Campaign for Tobacco-Free Kids on this, and in our Transforming Communities initiative, again, we've been doing this for 18 months, 4 cities in 1 state have passed. So and it was literally no more than $20,000 in any one of these communities that we contributed to really get movement happening around Tobacco 21. So the investment is not steep, but the collaboration is really important, and the person to facilitate that is really important. We hope to have Illinois on this list real soon, so keep up the good work. So I just want to share a couple stories. The way in which Tobacco 21 passes in every community is different. Sometimes it's local public health pushing their government entity to make a move on this. In Maywood's case, it was the chief of police, sheriff, I think, actually. I can never remember. Anyway, it's terrible. It's this gentleman on the far end of this picture, and he's also helped pass it in Bellwood or Melrose Park. I can't remember which one, but they're both working together, and he's leading the way, and he's working with all chief of police in Illinois to actually move this in every jurisdiction. So he's a champion, which is awesome. The motto is identify a champion and they'll make it happen, but they really pushed it because they were sick and tired of seeing cigarette butts all over the place. And so he had a pet peeve with that, and he really took it to the council, and it passed. And the mayor, had this really great statement about the future of the next generation. And then on the childhood obesity front, we have several communities who are doing some different environmental work. In Maywood, again, the Proviso Partners for Health, who lead sort of the work on transforming communities, have been expanding their community garden footprint. They now have 15 gardens all over the community that are being sourced by local farmers, that are being pushed back out through farmers markets, that are literally feeding the neighborhood, and one of them is across the street from the local high school, and so they use it as an education ground as well. Again, this is a small investment from the hospital, but it provides great return. In Springfield, Massachusetts, I love this story, and I hope it starts, coming around. We have a video that maybe we can share out with you all, but the local school district receives their food from Rhode Island. So there's all this carbon footprint every day of food transporting across the state to feed a school district. No local food is being sourced into the food system for the children. So they decided to build a culinary center. It costs about $30 million, but the city, the local hospital, Trinity Health, and Sodexo, the food service provider, said we have to do this, there's no other way, and it's going to open in the next couple months. I'm very excited to see it. But this huge culinary center, which will feed all of Springfield public schools and eventually serve all of Massachusetts once they get up and running, but it'll be 30% locally sourced food that'll be going into the school system. It's a job training center for the future food service workers, and they just opened a casino, for better or worse, in downtown Springfield. But they need 16,000 food service workers. So 16,000 jobs, which is a good thing. That's why I say for better or worse. And they need 16,000 jobs, and they need somebody to train those people to be qualified food service workers. So this is just really exciting. This greenhouse picture here is another investment that we made in Springfield to help source the culinary center. So just lots of really great work that once you put diverse minds in a room, they come up with really great solutions. And then finally, I just want to share the story in Langhorne, Pennsylvania, where it's actually a very affluent community. It's on I think there's a river. I know I drive over it, some sort of small body of water. And Trenton, New Jersey is right here, and Langhorne is right here. And Langhorne is very wealthy, but there's this pocket that's close to the river that is very poor. And there's no access to food, there's no grocery store, there's limited transportation, and I don't know if you can see, but this, oh look, you can see the water even. I didn't notice that till now. The line of people, in April through September, they hand out food boxes every week on the same day, and they, serve over 3,000 people during this time period. So it's just a really incredible investment. A small investment that this hospital makes. Trinity does not fund. This hospital does this as part of their community benefit program. So I think that the opportunities are huge for you in collaborating with your hospitals and helping them think about, that thing you donate to whoever, how about we align it with our chip and we invest in that? How do we think about working together with our hospitals so that when we have these priority areas, we're all contributing to the same sort of efforts so we see greater impact. So that's our journey, and we're always excited to share it and to learn from others. So thanks.